Well, welcome and thank you for joining us today for the discussion about how to extend specialty care to rural facilities. We have a couple folks with us today who have experience in this space, and really excited to be able to share this with our membership as well as the clinical population that serves rural patients across the country. Uh, we're facing many stressors in Montana, whether it's the relationship with the payers or recruiting and retaining of staff. Um, we also have some of the benefits and costs that came with HR1. There will be overtime reduction and public payer reimbursement, but there's also this immediate need to address the Rural Health Transformation Program and the expectations. And what we're going to talk about today actually has an alignment with all five initiatives that the state of Montana has applied for, and I'm sure overlap with many states across the country. And here, those are workforce, rural financial sustainability, the introduction and maintenance of innovative care models, really addressing community health, and then, of course, like onboarding technology that helps scale long-term healthcare benefits to communities that are financially sustainable. And so, with that, I would turn it over to Andrew, and you can make the introductions to the rest of your team. And
Awesome.
thank you for being here today, and looking forward to
Yeah.
learning about this.
Awesome. Thanks so much, Sean. Really appreciate it and the opportunity to be here with our colleagues in Montana. We're going to try to use some of our lived shared experience from Dr. Frazier and myself of what it's like to build a statewide collaborative. We're both from states that have done it. We've gotten experience doing it, and particularly, how does the new technology of the moment help make that practical? Next slide. I've been thinking about this for a long time. I went to the NRHA meeting over a decade ago, and presented my first paper on critical access hospitals showing that actually for many procedures and operations, they do better than their urban counterparts. And so it's always instilled this bias in me that in addition to knowing the things that we need to transfer and get to the big centers, there's actually a lot we can do great locally close to home. And just last year, we demonstrated that actually rural and critical access hospitals are getting better over time. In face of all the headwinds, they're actually improving. In trying to think about how to do this, I've literally tried to literally write the book. So I got to partner with one of your colleagues, Randy Zuckerman, and Cal Spell, literally trying to think how do you triage what should stay local and what should happen there. And although we can come up with the right answers for what to do, operationalizing it is really challenging. Next slide. And so I joined Viz AI about a little less than a year ago, and quickly found myself here in front of Congress. Congress said, you guys are one of the most oldest established AI companies in the United States. Okay, the first FDA approval, first CMS payment approval. Tell us how to do AI the right way. And by far, their number one question every single time was, how does this help rural communities? So next slide. Viz is fortunate to be an AI platform in over 2,000 hospitals, but one in four are rural, and we have a lot of great partners in these communities that have really taught us a lot about how to do care the right way. And I think you'll see with Dr. Frazier's presentation in a minute um, how that comes through. You'll hear a bit about one of our products in stroke triage, but briefly at the top is, the dozen steps it takes to get a patient from when they first present in the emergency room to definitive care, and then getting that down to just a couple steps. We'll send you all these slides. Next slide. But the evidence is pretty clear. Getting time to decision faster, shortening length of stay, improving access to patients who can get definitive care. And we'll walk through that a little bit more pragmatically with Dr. Frazier's section. These next couple of slides, we know you have a lot on your mind thinking about these five initiatives. Um, and we'll skip this slide and the next one. One more. And I'll just show you, go back one. Um, we've tried to think about what we can do to be helpful. And I want to plant these seeds in your mind as you're listening to Dr. Frazier for the next few minutes. Much of the success we've had with our AI platform has been in strengthening hub and spoke models, decreasing length of stay, improving access, embedding directly in the workflow. And the last one's my favorite, reducing futile transfers. not just figuring out who needs to be transferred, but also figuring out who's safe to stay local and to provide that care there and keep those resources closer to home. So with that, I want to hand things over to Dr. Frazier, a true expert in this space. He's a neurosurgeon and vice chair at the University of Kentucky, who over the last 7 years has been building out an incredible statewide collaborative. So I'm thrilled to hand it to him to learn from him how he did it and the lessons learned for what this might look like in a place like Montana. Thanks, Justin.
For taking the time to spend with us for a few minutes. Can somebody confirm that they can hear me okay? Perfect. So you can just go to the next slide. And these are my disclosures for you. Next slide. This was the impetus to start this process, where we started to see a lot of patients with large vessel occlusion strokes. And basically, in the absence of thrombectomy, if you go to the next slide, this MCA occlusion turns into this stroke, which, if you click forward, turns into that problem. And so this was for the longest time, was a basically irreparable, life-changing event. Next slide. And we know from, there have been a number of studies on this over the last 3 decades, but on average, patients with a large vessel occlusion stroke are losing almost just shy of 2 million neurons every minute. And, so the chance of a good outcome is decreasing rapidly as time goes on. For many years, it was thought that heart attacks are kind of a major time event. And I would argue that stroke is even more time sensitive. Next slide. So thrombectomy came along. Actually, the person who trained me how to do interventional neuroradiology was Pierre Gobin, who invented actually the first thrombectomy device called the Mercy Retriever from years ago. But it really started to take off in the early 2000 teens and culminated in some very major clinical trials that showed benefit. So if you go to the next slide and we go back to that angiogram, we can turn that picture into the next one and reopen that blood vessel. And what used to take hours back when I was training and, when the dinosaurs were around, now takes about 15 minutes to do. And so we've had an incredible increase in the technology to do the procedure. The big challenge is getting the patients onto the table. And that's really where the Viz technology came in. And we'll show you that in a second. So just so you know where I'm coming from, this is the stroke mortality map. And if you click the next click, you should see there's us, that little star there, and we are just in the belt buckle, the stroke belt. So we see a ton of strokes every year. Next slide. This is Appalachia, and you can see Kentucky's right there. We're right in the thick of the highest mortality in the country for stroke, which is in Appalachia, and where Kentucky has a 10% higher national average and then the national average in mortality. Next slide. So this is us. I don't know how much you know about Kentucky, but we're on that red star there. We are technically a metropolitan area, but you can see we're surrounded on all sides by rural counties, particularly in Eastern Appalachia. So we're very used to working with counties that might only have, maybe two, maybe three ambulances for the entire county. Next slide. And then you look at our drive times. So a 1 hour drive time is in the inner circle, the 2 hour drive time is the outer circle. So that barely doesn't even cover half the state. And I know that you all are familiar with that as well. The sheer breadth of geography that you're facing. And so that really creates challenges for figuring out who should come, who should go, how do you transfer patients safely? How do you use that limited resource of transferring patients? Next slide. This is us in terms of our stroke centers. The red stars are the locations where we have thrombectomy capability. Everywhere else does not. And so, I think that's a major issue, something that differentiates rural environments from most of the coastal environments like Los Angeles, New York, Philadelphia, where there's a stroke thrombectomy center on almost every corner. We are a limited resource. So if you look at your state, really you've got a handful of places that are performing thrombectomy, really only three major locations. From my understanding, the Western Edge really doesn't have 24/7 coverage. And this is a common theme, by the way. This is not unique to you at all. And it's a struggle that we're really having to work with. And so I think finding tools and using tools that can help us direct patients to triage them appropriately, to figure out who really needs to transfer, who do we really need to use those resources on, can be very helpful. And you'll see why in a second. Next slide. Similarly, you've got a lot of folks. Most of your population, at least by my calculation, lives within a few hours of a thrombectomy capable center. So that's good. That's good. But those hours, as I said before, that's a big drive time. A three hour drive for an ambulance. That's 6 hours. It basically takes that ambulance out of commission for most of a whole day, just doing that transport. And if you've got flight, that's great too. So, how does this work? Basically, a patient comes in, gets a CT, CTA, for stroke, and then that gets alerted. The scanner is hardwired. So there's a hardware component and a software component, and the scanner is hardwired to send that scan up to a cloud, which then sends it to my phone. So even while we've been sitting here, and you'll see this is my phone, and I got a Viz alert just 2 minutes ago. Thankfully, I'm not on call; someone else is covering, but you get the idea. These things go off all day long, and you have the ability to really look at the pictures. So part of it is the ability to look at the pictures, as you can see on that illustration. But as important is that HIPAA protected texting environment. So we can open up a text chain and I can literally sit there messaging the ER doctor from 2 hours away, finding out what are the patient's symptoms, their last known normal, is there any reason why we wouldn't do the thrombectomy? And if not, let's just transfer the patient. And I'll show you how that works. Go ahead, next slide. So when we started this, our goal was to improve patient outcomes, to actually help our community and rural hospitals grow their stroke programs. We were in a real pickle in 2020. Obviously, COVID was hitting, but we were also in a situation where we just didn't have the beds to say yes to every single stroke patient. And so we had to figure out, okay, who really needs to come to the Comprehensive Stroke Center? Who can stay in the community? And can we grow those community practices to take care of minor stroke? And that's really where we were. So if you go to the next slide, that's what we were trying to do. So this really helps patients because we can rapidly identify these patients who have critical needs to come to the Comprehensive Stroke Center. In addition, you're almost like it's not a telehealth service, but you're bringing that expertise virtually to the bedside. There's just as many patients that we see on Viz that we actually end up getting into clinic a week or two later because they need to see us anyway. So that really creates a very easy pathway to high level care. The patients love it. If you'll go back for just a second, the patients love it because they don't want to go out of their communities most of the time unless they absolutely have to. They got families. The family doesn't want to drive 2 hours just to see their family member in the hospital for no reason. And so I think that that's a very important thing. So if you go to the next slide. But the next few slides are not meant for detailed digestion, but rather to kind of give you kind of an overall profile of what we did and how we achieved it. So we started in 2020. It takes about a month and two now, although I think it's faster now to get the hardware installed. Then you do some organizational workflows. So we created some workflows, and the way it works for us is when we've got our neurointerventionists who are on the Viz, we've got our stroke neurologists on the Viz, but we also have our bed coordinators looking in on the Viz too. And so if we say we want to transfer a patient from a particular hospital to UK, that hospital does not need to pick up the phone and call the transfer center and do all that nonsense. We accept them, the bed coordinators see it, we ask the outside hospital to literally like take a picture of the patient's face sheet and it goes on Viz and we're done. And then they just put the patient in the transport and go. So it takes what used to be a 15 to 20-minute phone call and turns it into about 30 seconds. And so that has been absolutely critical in terms of creating that ease of workflow. And then there is a QA like a QA part time where you go live, but you're looking at scans. And we've done this. We've taken a number of hospitals through this. At this point, just to kind of know where we are, we're a hub. and we've got 40 spoke hospitals feeding into our Viz feed at this point. We also have a hub model, which I can talk about later, which is a very interesting way to collaborate between two stroke centers. Next slide. Again, I can provide this to anyone who wants it, happy to do for the details, but you can see we created this clinical workflow, and you can see that everyone's kind of looking in on the Viz and making decisions. Again, not meant for detailed digestion today, but I just want you to know these workflows are out there. And if you start to onboard and want assistance with understanding how to use this, I'm happy to provide this. Next slide. Experience in the first 5 months. So in the first 5 months of using it, we processed hundreds of scans. And of those scans, only a small portion really alerted for a large vessel occlusion. So there's going to be a ton of scans that are negative, and that's okay. That's okay. But it really helped us to build our workflow. Next slide. So it's a little confusing, this slide, but I think it's very important for us. So the light blue represents the number of patients each month. A dark blue represents the number of communications on those patients. So a patient would come in and there was a back and forth conversation in the text chain. And so we really made use of the text messaging feature. Again, I really would emphasize that to me, it goes hand in hand with the imaging and really creates that opportunity to bring the appropriate patients to communicate back and forth and to understand who can stay, who needs to go, who can go to clinic. And that's really key. Next slide. So in the first full year that we had it, like we collected one full year of data, we looked at almost 5,000 CTs, 1,600 CTAs, and we found 230 potential large vessel occlusions. Our average response time was 5 minutes. So for those hospitals, I don't know who's on the line from a rural hospital, you get that CTA, you wait for the radiologist to read it. They call you to alert that there's a problem. Now you got to get on the horn to wherever it may be, if it's Billings, et cetera. You got to wait on hold while they find the doctor and they look at it and they talk to you. Next thing you know, a half an hour's gone by. And so that was really key for us. It also, what was really interesting to us is that from 2019 to 2021, even in the middle of COVID, as we were bringing Viz on board, using the Viz actually helped us with our own door to revascularization times. So that was really a key improvement metric for us, at the Comprehensive Stroke Center. Next slide. Stand today. Now, these data are from December. So I'm sorry, I don't have the last 2 months, but since inception, we've looked at 17,000 patients, of which we've only transferred 1,145. So your transfer rates are extremely low. And I think that has been an amazing thing for both us as a comprehensive stroke center, as well as for our community and regional hospitals. Since inception of the program, we've seen 3 hospitals in our network go up for primary stroke center certification. And we've added a whole host of additional acute stroke ready hospitals as well, because they're keeping patients, because they can. And I think if the hub can partner with the spokes to do that, it's great for everybody. You could see that. That on that right side, I just provided a example of what a typical messaging goes back and forth, and you could see that. Next slide. Studies on this, and I can provide more resources if you'd like some of the data. We're doing some of our own data acquisition and research as well. But pretty much across the board, we've seen and now proven that not just in our community, but in others as well, there's been a real improvement and reduction of futile transfers, meaning reduction in transfers that were sent over to a comprehensive stroke center and then essentially nothing happened in terms of intervention. So I think that that's really important. And so you get this increase in the relative rate of thrombectomy transfers, and you're saving resources. And that's not just resources for the hospital. It opens us up beds for us to take care of more complex patients. It also reduces the burden on the communities, as I mentioned before, in terms of taking ambulances and air flights out of service to take patients that wouldn't benefit from that higher level of care. Next slide. So these are our own data from our institution and our network. So in terms of our network, since we started Viz, we've seen a 34-minute improvement in imaging to transfer acceptance, meaning prior to Viz, the images would have to be uploaded onto a little mobile radiology app we had. We had to look at them, call, talk to them, discuss it with the outside hospital. All of that went away with Viz. And so now we're at 21 minutes and we're always trying to get better. We saw a 17-minute door improvement in door to decision time. And the bottom one is the one that's really key because this is a reflection on a major metric that the Joint Commission loves to look at for smaller regional hospitals, which is their door in, door out time. And we've seen continuous improvements in that. Next slide. In addition, as I said, we looked at our own thrombectomy related institutional metrics. So our imaging to interpretation at UK has basically dropped by 3/4. And the imaging groin stick, now it's radial stick. We do almost all our thrombectomies radially now. Has been 30 minutes, and we've had a 30-minute time from imaging to first pass improvement. So this has been, interestingly enough, you would say, well, this is a triage tool for transfers, but it's actually helped our push forward our speed of treatment at the comprehensive stroke center. So good for that. Next slide. And you can see here our growth in thrombectomy numbers. I need to update this with 2024 and 2025. In 2023, we did 235 thrombectomies. You can see that line is where we started using Viz. And now last year we crossed the 300 mark. So we do 300 thrombectomies a year now in UK. Next slide. So really where the interactions, like I said, we're providing messaging and feedback through Viz. The other things that we are doing and engage with, it's not just that. It's about establishing the working together. So we've got quarterly dashboards that I'm going to show you in a second. About twice a year, we get on a Zoom meeting with our entire network where the spoke hospitals can, kind of give us a feedback on how things are going. And I actually participate in other hospitals' Joint Commission reviews to provide the Viz data to show that interaction, which the Joint Commission loves. Next slide. Report. This reflects all of our folks in terms of all of our spoke hospitals and their relative times. You see the average there, and then the top performers in light blue. So that's really been good for us. Next slide. Quarterly dashboard. I've removed the institution, but we send these out to every single one of our spoke hospitals to show what their quarterly dashboards look like in terms of data. Now, how do we do this? We have an FTE for a data analyst that is the FTE we got for Get With The Guidelines. So we had to get that FTE to input our Get With The Guidelines data, but she's not doing that all the time. So we use her as well. And she does an amazing job at putting together these quarterly dashboards. Next slide. So in conclusion, Viz improves stroke care intervals. We've seen this happen, improves interinstitutional collaboration, and it also provides opportunities to have networks of care. I mentioned this before. We also have a hub model where there's a hospital in Eastern Kentucky that does thrombectomy, but they don't do it all the time. And so whenever there's a patient comes into their hospital or one of their surrounding network hospitals, it gets looked at by both of us, and we let them kind of take the lead. Are they going to do the thrombectomy? But if they're not available, they send the patient to us. So it's a very nice working together to collaborate and really helps all institutions. So we really are an opportunity to keep appropriate patients in local regional centers, as well as to grow our own stroke center.
Dr. Fraser, thank you so much for your time today and the presentation.
Great.
Dr. Brett Abraham, thank you so much for bringing this all together, you and your team. We hope that we can, here in Montana, begin to move forward to implement at least part of this model across the state of Montana in the coming year.